Okay, this is part two for the renal system. Before I start going into the pathologies themselves, I want you, obviously, you're seeing this video, otherwise, you wouldn't hear me say this, but I want you to realize that from a structural standpoint, the renal system is pretty simple. We're not really going into the nephron, we're not going to analyze the structure of the nephron. Although it can contribute to your understanding, it's not cardinal to your understanding of what we're going to talk about. But I do want you to remember that every time that we talked about a vessel, a pipe that was leading fluids of any kind, that there were very simple mechanisms, especially mechanical, that played a part, right? So the diameter, an obstruction, complete obstruction, uh, um, partial obstruction. Where is the obstruction before an organ, leading to that organ, or after, right? And I want you to remember this one while we're going over the presentation together. Uh, uh, it's pretty simple, actually, to remember if you think about it. Then you'll see that the names of the conditions, for the most part, just give away the whole mechanism or idea of what the pathologies are about. Does that mean that you should respect this topic or not learn it well? Absolutely not. But it's relatively easy to understand what's going on. So let's start. I'm not going to address every single point. You have a lot of knowledge and tools by now, but I'm going to indicate the major one. So first of all, we have a UTO. A UTO is an idea. Anything that's going to obstruct to a certain extent the tract, the urinary tract. Another phrase for a pipe, right? For a vessel. In this case, it's a vessel that is leading or conducting urine. Is going to cause a problem with the flow. So it can be the diameter, it can be an obstruction. It's going to change the nature of the flow. And this is exactly the same ideas that we've talked about, the same principles, the same ideas that we talked about when we were talking about blood vessels. Only that there we were conducting blood, and here we're conducting urine. So, is it a huge change? Absolutely not. Obviously, if we're talking about obstruction, this is an anatomical issue that is going to lead to a functional problem. Of course, severity depends on the location, the number of locations, um, and then what is the extent of the blockage that we're talking about. Then for how long is the blockage, meaning acute, chronic, right? And the nature of the blocking reason, meaning is it primary? Is it secondary? Um, does it originate from inside the system, from outside of the system, and so on and so forth? So we can talk about upper tract obstruction, meaning if we look at the system as its parts arranged from higher areas of the body going downwards to where urine is going to come out at the end, right? We're talking about the upper part of the body right now. Um, so, of course, you can be born with problems. It can be anything that will constrict uh, the urine vessels, the urine tracts, right? So if you remember, anything that's going to mechanically pressure the tract and decrease the diameter. I hope that by now you have a list in your head, right? Any kind of mass, tumors, muscle contractions, fat mass, anything that's going to right, compress the tract and influence it. And then obviously anything from the inside that's going to decrease the diameter. Um, so you can see on slide 13, we're basically talking about uh, the ideas of constriction and deletion. In this case, more constriction than anything else that leads to blockage, either temporary, uh, acute, um, or chronic. And then you can see that hydrourethra uh, is the accumulation of urine in the ureter that immediately translates, hopefully, in your head and brain to an elevated pressure in the area. Um, then, of course, we're talking about the idea that if you have a blockage, and let's say the direction of flow is from up to down, right? From up to down, and you have a blockage at a certain point, then you have an increase of pressure. This is the blockage, right? Right here. You have an increase of pressure above the blockage when you look anatomically. So before the blockage, when you look at the direction of the flow, but above the blockage anatomically, because the direction is from up to down and it's blocking. So whatever is above it trying to go down is blocked, right? And you have an increase of pressure above the blockage. Underneath the blockage, the pressure goes down because less fluids are reaching that area. Obviously, if you have more volume above the blockage, right here, somewhere here, right, that vessel, that tract has to dilate in order to hold that fluids, that volume of fluids in the area. So that's what we're talking about um, in slide 14. And of course, you can see where smooth muscles that help, exactly like in other systems, um, you know, push the fluid forward. We might have either the obstruction or the hypertrophy of smooth muscles, um, and so on and so forth. Of course, if you have no movement of fluids, it's called stasis, exactly like we see in the vascular system. So a lot of things are the same. Um, then, of course, we have an increase of pressure. If the pressure is applied to the surroundings, to the environment, it may lead to injury. Non-complete injury will lead to scarring. Scarring leads to uh, the loss, either partial or full, of functioning. So you see this happen again and again, only that in this case, we're talking about the nephron, we're talking about the renal system, but the principles are exactly the same. The cascades and the processes and what leads to what is exactly the same. No new tricks at this point, right? And then you can see that there's a time, kind of a time scale or a timetable that if things are not treated, as you know, it's going to get worse because it is a course in pathophysiology after all. That other organs and other tissues in the surroundings start to be affected because it's all one great loop. So you see that within 2 weeks, the proximal nephron is affected because it's proximal, and then you can see that the within 4 weeks, the glomerulus, the medulla, and the cortex are damaged because those are a bit farther away and it will take a bit more time for the damage to get there. So you can see atrophy of the glomerulus, the medulla, and the cortex. Obviously, atrophy because fluid is not getting to that area, is not arriving to that area as much as prior. mechanical pressure goes down, the need for more mass goes down. It's exactly the same like with skeletal muscles. So now you have a decreased capacity, and it's going to affect anything from that point onward. So hence the list that you see on slide 16 in bullet 1. Then, of course, the system is supplied by blood, because we're filtrating blood if you think about it. Now it's going to reach the vascular system, um, which can occur very fast. And as you remember, you reach the vascular system, you're in a bad place, because the vascular system reaches almost the whole body. And then you can see that we have kind of a threshold of 70 days that we better catch it within those 70 days, where only partial function is damaged, whereas after those 70 days, give or take a bit, each person is different, right? It's going to get worse, and it's going to get way worse and faster. Then we see that we know that we have two kidneys, right? So yeah, when one is obstructed, the other one starts compensating. The question is, how much more does that other kidney need to compensate for? The more the compensation is greater, the worse it is for the other kidney. The good news is that the kidneys are very efficient, great organs, so it's not going to be that easy to negatively affect the other kidney that fast. But at some point, the other kidney might be overloaded and will start lacking function as well. So it's not a magical solution. There's only so far that this solution can go, and then you see that the other kidney, which is undamaged, hopefully increases in size, because it needs to increase its capacity, and it's reacting, it's adapting in every way possible to meet the needs of the compensation process. The process is reversible if the obstruction is removed, which shows the flexity of the system. Then you see that we have mild diuresis is common post obstruction. It's a very natural physiological response to the imbalance caused by the uropathy. And once that is restored, then we see that fluid and electrolytes are restored, which are very important to function, as you already know. Then, if the response itself, the compensation itself, is inaccurate, then you might get what we call an over response, right? So we're trying to correct things, but we overcorrect them. Now we're causing a pathology of the opposite nature. So if we had too little water or fluids, now suddenly we have an over response, and now we have too much water. So that would obviously cause an increase of urine per day, and you're losing too much volume instead of conserving. And you can see that the value, which I do want you to remember, is more or equal to 10 liters per day. What else? I want to talk about the main points and not every point, and more about the principles. I'm confident that you are able to go over this and sort this out. And if not, just shoot me an email, as always. So we can start talking about kidney stones. Basically, very simple idea. Very, very simple idea. you have a growing concentration of solids of different kinds. You'll see that the substance may change. That means that you have an accumulation of a certain substance. It's not liquid, otherwise, it would flow in the system. It is solid. It is solid, so we call it a stone. And it originates from the kidney. So there is an accumulation of a stone. It can be in different sizes. Obviously, the bigger the stone in the system, the more it's going to hurt, the harder it is to get out for the same substance, right? Uh, um, Making up the stone. And then the greater the function loss that it might create because it's a greater stone, so it's in the way and it's more obstructive. So basically, that's the idea of stones. Some will leave the system naturally, meaning that they are either easy to break down, meaning that their content is softer or does not create stones that are harder, or that they are small in size. Now, let's talk about the pain that it produces and the function loss or influence. If this is your diameter of your vessel of your pipe, right, the tract right here, and the stone is this big, then it goes through easily. You see, no pain, and probably not much injury to the environment, right? Although it's still a stone. But if this is your diameter and the stone is bigger than this, then you're asking for it, so to speak, only, and you have a bigger problem. Okay, so there's a relative ratio between the size of the stone, its content, how hard it is, and the size of the tract, the vessel that it needs to travel through to get out of the system. And then it might get stuck at, at a certain point and create a blockage. So obviously, this is a major thing to take care of, and it may lead to surgery if needed, right? To an external intervention, for sure. What else? I'm looking to see if there's anything um, significant. I want you to notice slide 23. And here's the question, right? The question about pathophysiology. What can go wrong? What can go even worse? What can make it even worse? So, if the content of the stone is one that attracts biological tissue, it will cause it to stick and grow in multiple, in a multiple ratio, way more than just the stone formation. Um, and this is, of course, worse. And one of the accelerators of this process of biological tissue sticking to the stones, making it bigger and worse, is the process of infection. Then the urine pH, the higher the pH, meaning it's more alkaline, the faster this process occurs and the bigger the stones get, especially those of calcium and phosphate. By the way, here's the pair again, calcium and phosphate. Remember I told you that you don't want calcium to be unchaperoned? Here's another example. So obviously now we have a way to classify the stones according to their size, according to uh, especially their major component of the stones. What else? So you see that we have acidic urine, increases the formation of uric acid, cysteine, and xanthine stones. Once again, basically, the main difference is the main component of the stone. Um, then you see an indication that a 5 millimeter, which is half a centimeter, right? Stone has 50% chance to passively pass, meaning without any help, or whereas a 1 centimeter, a 10 millimeter stone has no chance of passing. So it's a size game. Um, then you can see that you can have crystals at first formate. Then we have ICU, the idiopathic calcium formation of stones, meaning we don't know the reason, we know the outcome. In this case, it's a giveaway that it's made out of calcium and phosphate, or in this case, calcium and oxalate, but it definitely has calcium. And once again, I remind you, calcium has a +2 electrical charge. Right? We're talking about the table of elements. It's highly reactive. It's gonna bind with something, and you can see two options here already. Obviously, you have to have more calcium than you need, or some kind of imbalance, or something causes calcium to accumulate in the tract. So that's kind of a given. Uh, Basically, you have to have hyper or more than everything, which is indicated on slide, what is it here, 25, in the second point. Um, So anything that would influence the balance of calcium, loss of calcium in the bone, some kind of hormonal imbalance, dietary intake. I can tell you that I served on a committee in the Israeli military that we were trying to deal with serious neural problems that affected Israeli female soldiers that were accepted into newly opened positions in combat units in the Israeli military, in the IDF, and someone made the mistake of just bombarding their, just overloading their diet with calcium, because women have greater loss of calcium in compared to men, and it caused hypercalcemia. And boy, were we dealing with a wide range of problems. And that, I don't know the outcome by now. It was about 10 years ago, at least. But I'm guessing it caused them also renal problems at some point. So, and then it can also be, inherited, of course. Um, then if you look at the formation of the stone itself, you can have a nice, so to speak, smooth stone, unlikely to happen, or you can have a rigid stone that had spikes and branches, which obviously, when it travels through the track, right, it travels through the pipe, it has greater chances of poking, scratching, injuring the environment. So that's what we're talking um, about the staghorn configuration on slide 26, and that is worse. So, what is worse? Worse is big, non smooth, with biological tissue. Big, not smooth, right? Staghorn configuration, and with biological tissue. That is the worst stone, and of course, big meaning above 1 millimeter. So remember those three, okay? Um, Symptoms, obviously, pain, anything that has to do with changes to mechanical gradient, the increase of fluid, right? That will change the concentration, obviously, of urine, because you're playing with the volume of water, elevating it or decreasing it. Where is the pain located? That's very simple. In this case, the pain where the stone is located, where it's stuck or where it's going through, indicates where it's stuck, meaning that if it's going through your groin because the renal system, concentrates there, it's gonna hurt there. So we have, uh, okay, this is horrible to say, but the fact that you have pain in this case due to a renal stone makes it easier to understand where it is because the pain is where it's hurting. So it's a great indication uh, to where the problem is. Okay, of course we don't want people to suffer, but if they're going to suffer and they have a problem, it's better to know exactly where it is according to the pain than to have radiating pain that sends you all over the place and makes the diagnosis way harder. Um, let's see. It doesn't mean that you can't have radiating pain, right? But for most cases, it helps pinpoint what's going on. Let's see. Of course, you don't need to know the diagnosis and treatment. We're not going to address that. Okay, basically, uh, next point on slide 29 is the lower urinary tract, the LUT. Exactly the same ideas. Listen, there's nothing new here. Nothing new here. I want to put it simply. Same idea. You have a vessel, you have obstruction. Only anatomically, we went downwards. Okay? So it's the lower tract. Um, and we're going towards the bladder. So the bottom line is what it's gonna cause is storage of urine in the bladder. Okay? Bottom line. Um, or the lack of, meaning that the bladder is emptying more than it should. Okay, so we're going, and now we're focused. We're downwards. We went downwards in the system anatomically. We're not at the higher level of the body. We're closer to the floor, so to speak, and we're focusing on the bladder. And then you see that we have three options. One originates from the neural system. So we have a problem with the neural aspects of operating the bladder. Number one. The second one is obviously anatomical alterations. And the third option is always the combination of both. So, neurogenic bladder, the name itself means everything. Who's to blame? The nervous system. Where is the problem located? In your bladder. Okay, so neurogenic bladder is an LUT within itself. So you can see the definition as bladder dysfunction due to neurogenic disorders, meaning we're blaming the nervous system. Okay, and it is associated with the origin, meaning the difference in the specific problems of this LUT, of neurogenic bladder, originates from the specific sites in the nervous system. And you can see that the two main characteristics of the dysfunction is either motor or sensory, of course, or both. So lesions in the upper motor neurons of the brain and the spinal cord may cause problems in function. This is not new to you. We visited this idea when we talked about the neurologic system, right? And of course, any mass, as a lesion is a mass, will pressure mechanically the neuron and affect anything that's underneath it, right? So you see the lack of coordination in the function of the muscles. And in one case, you get an overactive bladder, meaning it's too active And an overactive bladder means that you're urinating more than usual. Um, or the other option, obviously, if you have an hyperactive bladder, you can also have a hypoactive bladder, and that means that you're accumulating um, fluids in the bladder. And two things are, three things are going to happen uh, to be very obvious. One, you're urinating less. That's number one. Number two, you're accumulating fluids in your bladder. It's going to press. It's going to apply pressure to the surroundings. It's going to hurt, in other words, right? And then the system is kind of one directional, right? We want urine to flow from upwards, downwards, and outwards. So if you have a problem in your bladder and it's pushing fluid upwards, now you have urine starting to go back upwards. Bad idea. Very bad idea, because you're also changing the mechanical gradients when it's pushed back upwards. And then you have a gradient having fluids going inwards, meaning instead of collecting fluids and disposing of them, you're accumulating fluids. Very bad idea, right? So with this problem, it might cause you to not able to hold the urine, and the dister will just empty the bladder, will just empty itself, once it's full. Meaning that you're not able to hold it in, so to speak, right? It becomes an urgency matter, and you don't even necessarily have any warning signs before. You might urinate on yourself without any warning. So, uh, uh, you know, then what are the reasons? Anything that can affect the nervous system. You can see a stroke, which is a major reason, traumatic brain injury, right? Dementia, brain tumors. Then, believe it or not, what slide is this? 36. That's actually something that exists with the kid. It actually exists. People sell it. I'm not trying to sell it to you, but people actually use this. So, a bit of humor. Um, let's see. So, in the next slides, you can see a list, which I want you to remember, of how the location of the influence in the nervous system affects the difference in the function, or the dysfunction, to be accurate, of the bladder. What's the simple idea behind it? When you affect different neurons at different levels, they are in charge of different aspects of neural function. You get different symptoms. So you can see that if the lesions occur, I'm on slide 37, by the way, bullet 1. If the lesions occur between the pontine micturition center and the sacral micturition center, it results in hyperreflexia, right? And that is going to influence the bladder, because it's going to contract the bladder and the sphincter at the same time. And now what you have is the bladder that is full of fluid, right? So imagine this is the bladder, which is a kind of sac, and you have the sphincter at the outlet where urine is supposed to come out, and they both go whoop. So the bladder is pushing fluids out against a closed outlet. Pressure goes up, and you have a problem, right? So that is obviously what we call a functional obstruction. Why is it functional and not anatomical? It's not that the outlet, right? This area right here, it's not obstructed by anything. But at the same time that the bladder is contracting, so is the sphincter which is not it's not what's supposed to happen, right? If you want to hold it in, you want your bladder to be relaxed and then the sphincter to be closed. But the bladder is contracting and the sphincter is contracting, closing the outlet. So you're just elevating mechanical pressure, and that's a bad idea. Okay. Um, so then we can see that we can have another problem with an atonic bladder, um, which means that the muscles of the bladder around the bladder decrease the tension, the mechanical tension, meaning that the bladder can enlarge and accumulate more and more fluids before it has to discharge itself at the same time. Um, and that means that you have a distension of the walls, which will cause you with a functional problem, right? And that's what we call underactive bladder. So you're not urinating as much as you can, but the bladder is enlarging. And when something enlarges in a body that is not highly flexible, especially with your internal organs, it's going to elevate the pressure on the side. Notice that in this case, your neurons, your nervous system is intact. Okay. What else? I think we'll stop here for this part, and I'll upload other videos as well for the rest of the presentation. So we'll continue from slide 40 with the overactive bladder syndrome, which you can already imagine what's going to happen. But part 2 will continue for slide 40. Stay tuned.